I have Dr. Rebecca Cain to come next. Let's give her a big hand.
Okay, good afternoon everybody. My name is Rebecca Cain and I'm Associate Professor in Experiential Engineering at the University of Warwick in the UK. Before I start, I just want to explain a little bit about what experiential engineering is. So it's actually a research group, and what we do is look at designing experiences for products, spaces and services, and we do that with and for people. So everything that we're about is involving users in design and putting them first. And all of the research that we do is about taking people's very subjective and emotional reactions to products, services and environments and trying to translate those into kind of objective engineering targets that we often find engineers need something more kind of quantitative to work with. And we kind of say that what we do is about engineering positive experiences. And just to give you some context to where our research group came from and how we've moved into healthcare, because we didn't always work in healthcare. About 10 years ago, we were predominantly working in the automotive industry, and we worked with Jaguar and Land Rover mainly, trying to basically engineer the positive sound to their vehicles. So we would do quite a lot of lab experiments where we would get people to listen to the sounds of engines and tell us how that made them feel, and then translate that into something that engineers could actually engineer a sound to. And then about 5 years ago, after I'd kind of been working in automotive for quite a while, I kind of saw a gap really to try and take some of the methods that we'd used for a very engineering problem and start to apply those to different areas. And for me, I'd been working for quite a while making very nice cars even nicer, and I wanted to try and do something that would actually help people. So experiential engineering has grown as a research group. There's now about 20 of us. And I think I'm really privileged actually to work with a really amazing group of people because we're very multidisciplinary. So we have designers, architects, psychologists, people from human-computer interaction, science, engineering, ergonomics, computer science. I'm actually a designer myself. And I think what makes our group really interesting and really helps our ability to work in healthcare is that we have people who have come from working in the health service for quite a long time. So we've had a nurse, we've currently got a physiotherapist, who really bring their frontline healthcare experience into an engineering department, which really helps us ground our research in some kind of reality. But added to that as well is that we work very closely in partnership with industry. So because we're an applied engineering department, all of our work is done in collaboration with industry, and all of our research projects are actually generated from problems which industry present to us, and then we try and find a way to help them, whilst also helping with our academic research as well. So in the UK at the moment, we currently work with many different healthcare trusts. We work with architects. We work with many of the kind of charity networks around mental health as well at the moment. So in terms of what our actual research into healthcare is, what we do is look at the role of design in how that can improve the user experience and the effectiveness of healthcare environments. And the way that we do that is to look at how participation and the involvement of people can be used better in the design process of healthcare spaces. And so what we try and do is to create better ways of involving users in design. It's really important for our group that user involvement isn't tokenistic, that it isn't something that's just seen as a tick box that's done after the project. It's something that we believe should be embedded right from the very beginning of all design projects, especially where health and well-being is concerned. So just to place some of our research in context, these are some examples of the types of research projects that we have worked on over the last few years. And then what I'm going to do next is explore two of these in more detail to explain a bit more about the types of methods that we develop in our group. So just to say really that all of the types of projects that we work on are across a very broad range of healthcare environments. So we've worked on traditional kind of hospital wards. So for example, we had a 3-year project which looked at the soundscape of a cardiothoracic ward. And this explored perception of the soundscape from from staff and from patients. We also made recordings of the soundscape as well, and then using our laboratory back at the university, we're able to apply interventions and modify those soundscapes to understand how the sound could be better. And what we actually found from that research was that it wasn't so much the sound itself that really affected people, it was whether they knew what the sound was. So if they knew that they could hear crying and that crying belonged to somebody that had dementia, that was okay. If they didn't know that the patient had dementia and it was just crying, that would stress them out. Other types of projects that we look at is because we're interested in the impact of design and how that actually impacts on people's well-being, we try and actually measure aspects of the built environment and see if there is a link to health and well-being. So another 3-year project that we had looked at care home design, and this surveyed 65 different care homes in the UK using a very detailed kind of checklist for environmental features. And then we also had data from residents in that home who were suffering from depression, and we looked at whether there was an actual link between design of care homes and depression. And what we found in that study was that the most significant finding was that the ability to access outdoor space was the thing that could make people depressed if they didn't have that. Other types of projects that we do, we look at infection prevention and behaviour change and ways that we can better involve medical staff in being able to wash their hands. And there's lots of things about the environment that can kind of help or hinder that. So we have currently a joint appointment with a researcher who's based in our group and in our local hospital, and we're actually doing some kind of hospital-based research around that at the moment. We've also done quite a lot of studies looking at, a bit similar to the talk by Naomi earlier, looking at what are the specific design features in an environment that would impact on how somebody perceives that space. So we also had another project which looked at waiting room design, and we had about 60 or so computer-generated images of a waiting room where very subtle design features were changed. For example, whether the chairs had padding or not, whether there was signage for the reception, whether there were plants. And then using a statistical technique called conjoint analysis, we got people to compare 2 images at a time to say whether they preferred those images and the extent to which it felt like a healthcare environment. Another project we did was to look at patient acceptability of telehealth. So in our group, we kind of see the healthcare environment of the future is increasingly going to be in the home. And a lot of what we do is try and understand people's kind of reactions to future technology and how that's going to impact on their lives. We've also done a nationwide survey with 120 healthcare architects in the UK to better understand their perceptions of design quality in healthcare. And we're also moving into the dementia space as well, and we're looking at the use of design knowledge in mental health design. So this is how architects can actually access the emotions and experiences of real people and use that to inform their design. Because currently, that kind of real tacit knowledge that people have about design isn't always in a very sensually accessible place. So we kind of have a philosophy that kind of underpins all of our research, and it's these 4 areas, really. So what we're interested in is methods. So how can you actually involve users in the design process of healthcare spaces? And can you do that with or without technology? And what's the most appropriate way to involve somebody in design? Following on from that, those people, once you've involved them, will generate data, which is normally about feelings. What does that data look like? How do we store it? How do we make it accessible so that other people can benefit from this knowledge that we collect? Third area is around representations. So being a designer, I'm always quite interested in how you actually present concepts to people, and if you want people to be able to feed back on those concepts and to tell you how they could be better, sometimes you need to give them something which looks less finished, so it gives them kind of permission to change it. And finally, it's about evidence. So all of this isn't much use if we actually can't generate evidence to say which designs are better for health and well-being, and also to generate evidence to say that participation by people in designing will also give better results. So the way that we do our research is to firstly always start with the actual lived experiences of the people who will use our spaces. So we always work directly with real users. And we try and develop new methods of bringing them into the design process in ways which are very specific to their particular environment and the way they're working. And so to do this, we've developed what we call situated methods. So our research is about gathering the experiences of people while they're in those spaces in a very real-time, immediate kind of way. We also, as I said before, try to gather evidence for the impact of design. And really, we believe that everybody is creative. And if we want people to be able to tell us how they think a space should be, we let them use creative methods to show us how it could be. And all of our work in healthcare is mainly with the NHS in the UK. So that's obviously our government-funded healthcare service, which brings its own specific challenges. And it is quite a challenging environment to do design research. So what I'll do now is just give you 2 examples of some projects which we've done, and just to show you the types of methods that we use. So the first environment that I'm going to show you is a project we did with an emergency department in a hospital in the UK called Plymouth. And what we wanted to find out there was how the design of that environment actually impacted on stress levels in the staff, and how it impacted on their opportunity to be able to cognitively and emotionally restore from quite a stressful job. Following on from that, we then wanted to look at how the environment could actually be changed to reduce staff stress levels and provide opportunities for restoration, and whether we could actually prove any benefit to those modifications. And finally, what was really interesting for us was that we needed to develop quite specific ways of working with the people who were in this emergency department, because they were incredibly busy, they didn't have much time, but they were very passionate that they wanted to be involved in this research. So they said to us, okay, we're going to be involved, but we don't want boring questionnaires, we want something that's interesting, and it has to be quick. They hadn't got time to go out of their day job and sit in focus groups and workshops. So what we did was to develop a series of situated methods. So these were methods which would allow the staff to tell us firstly how they were feeling about the environment, and if there were any particular moments during the day or specific aspects of the environment which induced a feeling of stress in them. So we developed a series of postcards which had some quite probing questions on them, and we positioned these around the emergency department alongside a postbox. So the idea was that if they encountered a stressful experience in which the environment had contributed to that, we got them to quickly write down on this postcard what it was that had triggered that and how it made them feel, and if they would suggest an improvement. And the post boxes were situated in the emergency department, and they were there for about a month. And doing that exercise, we collected an awful lot of really emotional, very qualitative data about how people felt at a very specific moment in that department. And then in parallel with that, we also developed what we called a stress walk. This was where the researcher would walk around the emergency department with a member of staff and actually conduct a walk and talk interview where they would get the staff to actually point out what aspects of the environment were causing them to be stressed. And we would also take photographs of that. So we had a very visual kind of documentation about the specific parts of the environment which were stressful. And so what that enabled us to do by putting those 2 methods together was to really understand what it was about the emergency department which caused stress in staff. And what we actually found was that it wasn't any of the clinical spaces which caused them to be stressful. It was actually the space that they would go to get away from it all. So this quite shocking image is actually their staff room. It's actually a windowless room. It's an old room that used to have a bed in it. You can still see the bed rail. There's an oxygen pipe on the wall. There's no window. This was where they go for a break when they have 5 or 10 minutes. They have to eat there. They store all their belongings there. It was really quite a depressing room. And actually, from the research that we did, this was the one thing that came up that everybody said, if you could improve our ability to be able to get away from our job just for 10 minutes, that would actually help us a lot more than improving any of the clinical spaces. And interestingly, they did have another room that they could go to as well, which did have a window and a view of outside. But you can see from the pictures here that it was actually had bars in front of it, so it felt more like a cell. So what we had to do then was to try and work with the staff to get them to come up with ideas for how to improve that environment. And again, because they didn't have much room in that space to actually we couldn't really use the walls to put things up. We couldn't really work with them in there to do any designing with them. We had to come up with a method whereby the staff could actually tell us how to improve that environment in a way that was very specific to them. So we developed a kind of kiosk. We called it a kiosk. It was very prototypey, but it was essentially built using an iPad and a big screen and an app that we designed, to basically get people to be able to tell us how to improve that environment by drawing. So we could upload a series of design challenges onto this with photographs. And because this was situated in the corner of their staff room, when they had 5 minutes and an idea, they could kind of draw their idea or type it onto the screen. And what this allowed, because this was a public thing in their staff room, other staff could actually see what other people had written and vote over the top of these ideas and suggest things. So it became quite a collaborative kind of design tool. The benefit being that actually the research team didn't need to be there to facilitate it. And again, this was there for about a month and allowed people to, when they had a moment, to be able to tell us how they would improve that space. And these are just some images showing the interface. So what should have happened then was that we take those findings, we give them to the hospital trust, they then improve the environment, and then we go back in and measure the stress levels of the staff. What actually happened was, with this being the NHS, was that they lost their funding to actually change the space. And only now, 3 years later, have they actually been able to take our design guidance on board and actually create a new staff room, which we're shortly going to go down and hopefully do a kind of post-occupancy evaluation. And just a very quick overview of another study that we did was to look at how a wellbeing centre should look and feel. This was a wellbeing centre in a hospital in London where they approached us because they decided to build a wellbeing centre, which would be a kind of public health drop-in centre for weight and blood pressure. But they didn't actually know what it should look like and how it should feel like. So we, as the researchers, became the interface between the trust users, the hospital, and the design team. And we conducted quite a lot of co-design research using, again, quite prototyping, quite rough, quite quick and dirty methods with trust users to really get to understand how they thought this space should look and how it should feel. Because these methods were quite quick and quite playful, we could actually really extract what people's feelings were from these, and then also look at the academic literature as well and put the two together to come up with a set of kind of recommendations for what this centre should be like. Again, we also used our kind of co-design kiosk as well to get people's opinions on the designs. And these were the types of areas of guidance. We wrote a huge report from this, which went to the hospital trust. So just to sum up, so participation of staff and patients in the design process is really important for understanding people's experiences, and this shouldn't be tokenistic or it shouldn't be an afterthought. And crucially, the methods of involvement need to be appropriate for the people involved and for the stage in the design process. And what we found in our research is that actually the staff in the hospital, particularly at Plymouth, weren't so bothered about the actual environment because the culture in which they were working, they were more concerned about actually being able to do their job properly. And so I think as designers and architects, it's about really framing the questions in the right way and not kind of saying, do you like the red chair or the blue chair? It's about saying, how could this environment better be designed to support your job? And finally, we think that situated methods which gather real-time experiences of people work really well because it's more useful to be able to collect experiences as they happen rather than sometime afterwards. And we believe there's quite a lot of potential to develop situated methods much further, especially digitally. But if we are going to go down the digital route, we need to actually validate whether those digital methods are better than any of the traditional methods that we can use. And I think really for us as researchers, the ongoing challenge is to generate more evidence to show the benefit of user engagement in design. Thank you.